Um, There we go. Thanks, Kate. So yeah, today we have a presentation from Heather Tomaszewski and Eugene Sue, and they're from the Alberta Health Services Home and Community Care Program. And I'll be talking about client-directed care. And then we'll review our resources. And then our next meeting is May 28th at the same time here. And Arlene Hunn from the Alzheimer's Society will be joining us to kind of give us any updates and an overview of what they are providing. So I think now I'll stop sharing so that Eugene can bring up their presentation.
Thank you. Just bear with me for 1 minute. I'll pull that up. Okay, hope everyone can see my screen here.
That looks great, Eugene.
Perfect. Thank you so much for hosting us to speak at today's Connecting Care and Connecting People at Community Partners meeting. I'm Eugene C., and I'm here with my team's director, Heather Tomaszewski. We work on the Home Care and Clinical Specialty Projects team under the AHS Provincial Seniors Health Department. And our team specifically helps to support the standardization of home care services across all zones across the province. And to do that, we help with policy development and education, amongst other things. So it's my pleasure to provide this presentation on overall home and community care and client-directed care. There's been some exciting buzz going around the province about a new service or concept of client-directed care. And the team that Heather and I work on are helping to establish that service across the entire province. And so Helen Lightfoot graciously invited us to speak to some of that work. So in order to talk about client-directed care, we have to do so in the context of AHS home and community care as the service that is delivered through AHS home and community care. So what we'll do is we'll go over an introduction of home and community care. We'll talk about how the public can access this service. We'll talk about the role of the home and community care case manager a little bit. We'll talk about how services are determined. We'll then proceed into service delivery options. And then finally, client-directed care overall as a concept. And then following that, we'll open the floor up for questions, and Heather and I will do our best to address anything that you might be curious about. Okay. So what is home and community care? Well, we're a branch of AHS that provides health and personal care services to Albertans to remain well and as independent as possible in their own homes. It often surprises people to hear that we provide the service to Albertans of any age, even infants and children. We offer a significant range of services available, including case management, professional care, personal care, and also that aforementioned client-directed care service option. We support caregivers. We offer an adult day program service as well as restorative rehabilitative care. And we also have palliative and end-of-life care as well. We provide this set of services to quite a large number of Albertans every year. As an example, in the 2022-2023 fiscal year, 127,012 unique home care and community care clients were served. The overall philosophy of this home and community care program is to promote client and family independence. We work with our partners in acute care and other community care programs to optimize outcomes and services for clients and families. So what are some of the goals of home and community care? Well, most everyone wants to stay healthy and independent for as long as possible while staying closer to their social network in the community. And that's one of our direct goals as well. Also, caregivers are recognized as playing a huge role in providing client care, and we appreciate that, and we look to support them as best we can with our services. And that's one of our other goals. No one wants to go to the emergency room or have a prolonged stay in the hospital. And one of our other goals is to provide any way to reduce the need for such services and episodes through our service provision. We also support early discharge from hospital, if possible, through our services. Some clients need higher levels of care, and we do what we can to try to delay or even prevent this from occurring. And another primary goal of home and community care is to respect the individual's choice to live in their own home, closer to family and friends. We work in partnership with families to do so, but we also cannot replace those family supports or provide 24/7 care in doing that. Okay. Home care can be overall seen in kind of two ways. We either provide it in a long-term capacity or a short-term capacity, and over half of our clients are of that kind of longer-term capacity. And we add family community supports for those clients who have higher levels of care, who might need to be placed in higher levels of care, and those are considered our kind of long-term cohort. They mostly receive personal care supports, quite a bit of case management and system navigation. They often also have some chronic disease management that requires supports. And so those are the focuses of our long-term clients. We also have short-term client needs, and those are individuals who we often see after their acute care episode or after surgery. Usually that means wound care management, IV management, but it could also mean other things. They may have equipment needs for the short term. They may have end-of-life needs. They may have mostly professional nursing needs. It often surprises people to hear about where we could be offering home care services. Um, this can be provided in a whole variety of areas, as you can kind of see in the diagram here. It's important to kind of note that the slide speaks to the range of possibilities for where home community care services could be provided, but not all regions of Alberta have the same or are quite the same in terms of what services are provided in these locations. So different services are offered at different locations, and you may not expect to see the exact same service in a private home that you would find in a school or supportive living accommodation. Okay, but this just speaks to the range of possibilities. So I'm going to ask you to bear with me for a minute with this particular diagram. We're talking about how people can access home and community care. And so this busy infographic speaks to a couple of things. First of all, we have community care access phone numbers there in the bottom left-hand area of the screen. And really anyone who has questions or requires information on home and community care programs and services can contact that local intake number. Friends, family, neighbors, health professionals, anyone can call in on the behalf of a client or individual. And then the central intake office there will confirm consent with each client. Okay. But what I wanted to talk about with this particular infographic is this describes the process for how clients can receive services through home and community care and how they would have a constant monitoring of case management service throughout that journey. And that's the really important thing to take away from this diagram, as busy as it is. And this is an old infographic. It's being redeveloped and it will be replaced soon, hopefully this year. But in the meantime, it's something that we still use to describe home and community care services and continuing care services. But the important thing to note is that case management is an integral factor to how clients access home and community care service. They're involved with the client throughout their journey. Those individuals providing case management do that. They will assess the client for services. They will constantly reassess that client as their needs change. They'll be monitoring them quite closely. And then they'll be involved in this care planning process. And that's kind of what this circle here is getting at, is that there is a very large care planning process that takes place with the client, whereby the case manager will work with the client and the family, determine what the care needs are for that individual. And that can change over time. Okay. So to speak a little bit more about the case manager, as I mentioned, the case manager is a very important individual in that client journey. Every single home and community care client is assigned a case manager, and their role includes assessing a client for the care needs they might have through home and community care options. They will coordinate those services for that client. They'll be, of course, as I mentioned, working with the client directly, negotiating with them to help achieve their goals through that home and community care. They also overall serve as stewards of public resources, and also have expectations to be working with the client as leaders, educators, and advocates for their client care. Okay, so how are services determined? And this is just a very general way to describe how case managers are expected to complete comprehensive assessments to determine what the client's unmet needs are in home and community care. And to do that, they'll utilize a standardized assessment tool. And you may have heard the names of some of those tools before. The RYE Home Care is an example of that tool, but it's not the only assessment tool that case managers use. They'll conduct that tool and then use it in conjunction with their clinical judgment, with an interview with the client face-to-face, to determine what sort of care can be provided through home and community care. The case manager will also consider what we call the provincial home care service guidelines to assist that clients get an equitable service based on what their need is. And as I mentioned on the previous slide, the case manager will work to develop a care plan to address the client goals. Okay. One thing that I want to mention is that the client's assessment isn't strictly based on a diagnosis necessarily, but really on the individual's situation with their entire holistic perspective. So a case manager will look at a client's formal and informal supports. They'll look at the client's management of that chronic disease that they may have, and then they'll incorporate all of those factors into that comprehensive assessment. Okay, so the services that result from that assessment may be different for different people, depending on their specific circumstance, even if two people had the exact same diagnosis. So this busy diagram speaks to the overall set of home and community care service delivery options. And I wanted to bring this here to show you that there's a kind of spectrum. That's the main takeaway from this slide, is that there are 4 main service delivery options at this time. We may be growing that over time, but this is how we think of our service options right now. And if we look at this table from left to right, what we're describing is a set of services that move from greater AHS involvement and accountability from the left to the right to more client accountability and responsibility in services, and therefore flexibility. So some of those services here, AHS in-house services, this is a service that's offered in some zones, primarily in the North Zone, for example, and suburban and rural zones. This is a service for personal care supports that's provided directly by AHS staff. Okay. And next to that, we have contracted agencies, AHS contract agencies. So what that describes is an arrangement between AHS and care provider agencies. Contracts are established between them to provide services. And so those services are provided by those care providers directly, not directly by AHS for personal care supports. As we move further, these green highlights speak to those client-directed care options, whereby clients are having more responsibility, more autonomy, more flexibility with these home and community care service options. And I'll get into more detail about that in the following slides. But what I wanted to show here is that there is a kind of range of options that are available for Albertans for home and community care. So client-directed care, what I want to mention is that this term is actually a relatively new term, but it also describes some services that have long been established for decades already within AHS home and community care, sorry. But the reason that we're looking at developing more options along these lines is that we're hearing from Albertans that more clients want to direct their own care. They want to have more flexibility with their service provision. And so we're looking at ways that we can allow those clients, individuals to manage or self-direct their own service delivery. In this kind of overarching concept of client-directed care, clients can determine who provides their care to a greater extent. And we'll talk about how that might differ between some of our two client-directed care options. And so the clients would have more power in determining how their care is provided. And one important theme is that the client would hold their relationship with the care provider instead of AHS. And again, I'll certainly get into that a bit more. And so we can see quite a bit of flexibility or increased options that can be specified for clients to meet their needs. There can be the provision of culturally specific care if clients can kind of choose specifically who their care provider is, down to potentially the specific individual. And so this overall also improves access to services in geographically remote areas across the entire province. We do try to have same set of service options available across the entire province, but the reality is that some areas across the province have certain geographic challenges. And staffing in those remote areas can be very difficult. And we're finding that this set of client-directed care options can help alleviate some of those gaps. So under the overarching umbrella of client-directed care, we have two main options, as I described in that kind of table with the green highlights. Client-directed home care invoicing and self-managed care. So I'm going to speak to that first option. This is the new option that is being established across the zones, and something that you've probably heard some buzz about. It's causing quite a bit of interest. So what is client-directed home care invoicing? As I mentioned, this is a new home support service delivery option that supports client choice. It is an alternate option to those other three options that have been more longly or more historically established, I should say, with AHS, those contracted provider options, the in-house healthcare aides, and self-managed care. But what is the hallmark of this particular option is that the client chooses the specific care provider. And there is no exchange of money that they're involved in. What happens is once a client is assessed for their care by the case manager, a care plan would be developed for that based on that assessment. And then the client would be notified that if they want to pursue this client-directed home care invoicing option, they could select a care provider through Blue Cross. And I'm going to take you through that website in a little bit to show you how that could be done. And once they select that care provider, the care provider themselves the agency would submit a claim directly to Alberta Blue Cross. And so there's no exchange of money that's involved, no financial responsibilities that the client would have in this scenario. It's strictly just involving an invoice between the care provider and Blue Cross. And then the client would receive that care. And I'll get into that a little bit more, but I do want to spend a little bit of time talking about Alberta Blue Cross and why this group is involved. And overall, what we want to do in AHS is we want to simplify the overall process for accessing home and community care options for clients and families. And Alberta Blue Cross does that. They basically take on the responsibilities of establishing and finding care provider agencies that meet a certain minimal set of requirements that can provide services for clients. Alberta Blue Cross will take on the responsibilities for the billing and financial management. So there will be no involvement from the client and family to do that. There would be therefore no sort of legal contracts or banking setup that a client would have to engage in. And then simply the Alberta Blue Cross can engage directly with the care provider agencies for whatever their needs are. As I mentioned, the Alberta Blue Cross registers these care provider agencies to ensure they meet a very minimal set of expectations. Really what that means is they're expected to see that these care provider agencies have a minimum set of employment standards met and that they have insurance requirements. But beyond that, there's not a lot of other monitoring at all right now. And so it's an important note that neither Alberta Blue Cross nor AHS ensures that any of these registered care provider agencies meet any other service quality standards. It's really up to the client to monitor service quality. And that's kind of, the trade-off, really, we could say, is that with increased flexibility and autonomy for clients in making choice, that also comes with some additional responsibility that they would be taking on. I'll take you through the website just for a minute here, if you can just bear with me. I'm just going to share my screen for, let's see. Bear with me for a minute here. Whoops. Sorry, it's on the wrong page.
Eugene, I just want to let you know there's a few questions coming in the chat as well. So I don't know if you want to pause and maybe if we want to discuss a little right now, or if we want to wait till the end of the presentation. And I don't know what your preference would be.
Yeah, I mean, I would be happy to, let's see, I think it might be best to continue with the presentation and then go through the questions afterwards. But Heather, do you have a preference for how we proceed?
I'm good with that, Eugene. I'm trying to answer some of them as I'm reading through. So I'll try and answer what's in the chat, and then at the end we can answer what I haven't answered.
Okay, perfect.
That sounds great.
Thanks
Thank
so
you,
much.
Heather.
Okay, so just bear with you for a minute. And I'm just going to take you through I hope everyone can see here that I'm at the Alberta Blue Cross website.
Yeah.
Yes. So I'm just going to navigate to where the client-directed care options are, where you can see the list of registered care providers. I'm going to ask for some involvement from the audience here as well. So just bear with me for a minute. So to navigate there, I'm just going to click on the menu, and then I'm going to go to the resources section. And then there's a drop-down list here, including government-sponsored programs. I'm going to click on that. And then we can see that there's another drop-down list of a client-directed home care option. So I'm just going to click there. And we're brought to this page that describes a couple of general concepts about how you can access home care. There's information for providers, for care providers as well. But what I wanted to take people here for is to show you how a client who's seeking client-directed home care invoicing could use a built-in map that Alberta Blue Cross has set up. This is a map that allows for those individuals to search for care providers within their region specifically. And there's been an initial setup of certain filters that could help a client find exactly what they're looking for. So let's imagine that a client had been looking for an agency that could provide them with, minimum 3 to 4 hours per visit. Actually, let's go with zero to 2 hours per visit. And then I'm going to choose whatever rate is available. And I'm going to speak a little bit more about that in a bit. But I'm just going to select, let's see, $31 to $35, let's say. And then in the search field, I can type in a postal code. So does anyone want to ask for a specific postal code? I'm just going to ask that someone just verbalize it to me if possible.
We've got T9J1B4. Thank you, Tracy.
Oh, did I catch that right?
T9J1B4.
1B4.
Yeah.
There we go, at Fort Mac. Okay, so you can see that there's a drop-down list of options, and so we can confirm that that's the right location. We'll click on that, and then we'll see the list of results down here based on our criteria above. So our filter criteria here, and that shows us here the agencies that are currently registered with Alberta Blue Cross that meet that criteria. And we do anticipate that this list of registered care providers would grow over time. We're seeing that actively happen as more agencies become aware of this service. So we're doing our best to kind of grow this option as much as possible. So you can anticipate that this list would be changing potentially weekly, depending on the region. Okay. Okay, I'm just going to go back to the presentation here. Just get that set up. Okay. So our next slide is speaking about those care provider agencies. It's important to note that these care providers have a relationship with Alberta Blue Cross, and that there's really no relationship with AHS. I mentioned previously that they are expected to meet some minimal requirements. So that speaks to things like insurance requirements and staffing requirements like the criminal record check. It's very important to note that AHS is not involved, not responsible for training the staff that work for these care provider agencies. We also don't provide them directly with the care plan that's provided to the client. We do not pay these agencies directly. We also don't oversee that relationship between the client and the care provider agency. So really, I hope that I'm conveying that there's a greater set of responsibilities placed on the client who chooses to pursue this option. And that's the expectation for their increased flexibility and autonomy. It's also worth mentioning that these care provider agencies can set up their own rates and can set up minimum call-out times, and that they may add extra fees or additional charges to the client. AHS ultimately does, of course, pay for the service that Alberta Blue Cross is billed for from the agency, but we pay a certain fixed rate, and anything beyond that rate would be expected, that cost would be expected to be passed on to the client directly. And we communicate that to the client. In fact, all of these responsibilities, all these processes are outlined to clients and to staff, of course. Right now, through education that's done in-house, we have a client handbook that is being finalized for development, but we have a version of it set up in all zones that offer client-directed home care invoicing that guides clients through the expectations for this process. And I'm going to speak to some of those processes here. So one of those expectations here is that the client, as I mentioned, has to assume quite a bit of responsibility with this autonomy, with this flexibility for CDHCI or client-directed home care invoicing. They have to have either themselves or an assigned client-directed home care invoicing manager sign a form, consent forms, and agreement forms between AHS. Of course, the client or the manager has to choose a care provider agency from that Alberta Blue Cross site. And then the expectation would be that this client and manager would have to direct the client care and monitor any quality issues they have with the agency. AHS has no involvement or responsibility with service quality whatsoever. Any charges, as I mentioned, set by the agency over and above what's outlined within the CDHCI agreement are the responsibility of the client or the CDHCI manager. And also the expectation is that this client or manager informs AHS of any changes to the client condition and of any changes to client contact information. Finally, they would be expected to establish a backup plan in the event of agency absences. And AHS, again, would not be responsible for providing backup care. So I hope you can kind of see that as we talk about CDHCI, the responsibilities have increased for the client as part of this service option. So I'm going to speak a little bit about self-managed care. And as I mentioned previously, this is another option that's actually been a long-standing option that's considered a client-directed care option, but we have long called it self-managed care. And it's been operating for decades. It's been very well received, very well established. It is really right now the ultimate way for clients to receive the most autonomy in terms of their home care service provision. Okay? But there are some additional requirements that are made of the client in this scenario. It requires an actual legal contract between the client and AHS. And it also allows the most flexibility out of all those other services. It can establish the most stable caregiver because the agreement holder, the person who signs the self-managed care agreement, actually has to take on the responsibilities of hiring a caregiver themselves. Basically, they become a kind of small business owner, and they become an employer. And so they have to find a specific caregiver who could be providing services to them for years in a very steady fashion. And that's something that is often quite appealing to individuals who seek out or ask about self-managed care. So this is really the best way that clients have to kind of meet very specific language and cultural considerations and needs. Of course, we do try to accommodate those through our other service delivery options, but this, as you can probably imagine, is the most direct way for a client to achieve that. So here are some of those responsibilities. As I mentioned, the person who signs the self-managed care agreement is called the agreement holder, and they need to become an employer. And so they have to behave very similar to a small business. Essentially, they have to meet all the federal, provincial requirements of being an employer. And then on top of that, they're responsible for all of the conditions that are outlined within the legal contract itself, which are quite extensive. They're also responsible for completing financial audits, because in this scenario, what happens is AHS will provide funds directly into a bank account that is set up by the self-managed care agreement holder. So there is quite a bit of financial involvement and responsibility, and that's what makes this particular service option unique and different from those other options where there's no direct financial involvement by the client whatsoever. And that's something that's expected in this scenario. And as I mentioned, they're responsible for finding and hiring the caregiver entirely. AHS is not involved in that at all. We would not have any sort of involvement with the quality of care or too much say about who is providing that care. Okay. But we would of course be monitoring that client in terms of how their services are being provided. We want to make sure that their care needs are being met. And if there are problems, then we will provide, we'll negotiate and to deal with that with the client. We'll work with them to do that. Similar to client-directed home care invoicing, the client who engages in self-managed care is responsible for having a backup plan on their own. And so we wouldn't, AHS wouldn't be responsible for providing services in the event of any sort of gap in delivery for whatever reason. So I've mentioned quite a bit of detail between CDHCI and self-managed care, and I wanted to summarize some of the differences between those two client-directed care options. And I'm hoping that this nice clean table provides that information. But what we see is that with client-directed home care invoicing, the staff is employed by the agency that the client selects. These agencies have to meet insurance and criminal record checks. And a person who engages in the client-directed home care invoicing, a letter of agreement, they can do so without any sort of legal authority. That's one thing that I didn't mention clearly before, is that really a client can assign anyone to be their CDHCI manager. That person, as I mentioned, does not have to have any sort of formal legal authority or legal representation. There's no monthly payments or that are being made to the client in this process. Really, it's as simple as I mentioned. The provider agency submits claims to Alberta Blue Cross, and billing is handled very cleanly without involvement of the client whatsoever, unless the client has received additional charges from the care provider agency. And we make that clear, of course, in the education and in the agreement, that those sorts of things could happen, the responsibility of the client. With self-managed care, the person entering into an agreement with AHS does have to have formal legal representation or authority to do so. They can hire any individual to provide their care. They can hire an agency. They can hire an individual with any credentials to provide them with the care. And again, that's entirely the responsibility of the self-managed care agreement holder. We don't mandate any agency or individual to meet any sort of requirements. Those requirements for staffing would entirely fall on the self-managed care agreement holder, who would be responsible for any of those federal, provincial employment requirements. And again, the big distinction is that in self-managed care, there is quite a bit of financial involvement directly by the agreement holder or holders. There could be multiple holders of agreements for in self-managed care. And they would receive a monthly deposit directly from AHS. And then audits would be expected of them at a certain frequency, usually every 6 months. So that brings us pretty much to the end of our brief high-level discussion of home care and client-directed care service options. I'm hoping we can kind of open the floor to questions, and I know that Heather's been doing an awesome job of answering some of those questions in the chat box. Are there any? Perhaps we should start with any questions that need to be answered verbally. I'm just going to stop sharing my screen here.
There's a couple, Eugene, that I'm not the expert in self-managed care, and Eugene is. So the couple questions that were asked specific to that. Sorry, my chat keeps flipping from, I had it on my other screen. Just let me catch up where I was at. They want to know the funding for self-managed care. That was the first question.
The rate, yeah.
The rate. And the second question was around a list of agencies for handling payroll for self-managed care.
And I'll just add in there, sorry, the one that was asking about the per hour, is there anything extra issued for accounting costs to help pay for somebody to do the accounting?
So right now, the rate for self-managed care is something that we are looking to make a case to improve and enhance. Heather and I are very aware that there's some interest in doing that, and we see the need for that. But right now, the rate should be around 25.74. I could be off by a little bit, but that is also a rate that's adjusted for inflation. Should be adjusted every year, and that's handled by AHS Finance. But you're probably thinking that sounds like a rate that's a little bit different than some of the rates for other services, and that is indeed the case. And that's why I mentioned that Heather and I are interested in making a case to increase that if possible. But of course, those decisions are well above our pay grade, but we certainly do want to advocate for that. The other question about the accounting kind of compensation or funding for for that. There is the allowance for possibility of a certain amount of money. I believe it was, I wanted to say $50 per month. I could be wrong, but I'll have to verify that. That could be billed in addition, or billed to AHS for that kind of accounting practice. We don't have a list of agencies that would be providing that type of service, but one of the major groups is RAPS. They're a group that provides that accounting service for people across the province. Most of the time, they provide that service in the Edmonton area and other geographic areas, but it's not something that's available throughout the entire province for everyone, unfortunately. And that's not an agency that is part of AHS. Of course, that's something they're just their own independent community group that provides that service. So we recognize that accounting can be challenging in self-managed care. And so we do provide some funding to allow for clients to do that. But it is also something that we factor into those discussions for determining whether a client is appropriate for self-managed care. We do ask whether they can take on those responsibilities. We do outline what some of those expectations are. We try to let the client have an informed decision, to notify them that these are the processes, these are the expectations, and we want to see whether it's a good fit. It may or may not be, but we do help assess that. And I might have missed another question along those lines. I apologize.
I think we kind of combined those ones there.
Yeah.
Yeah, Eugene, with it. I just see we have a couple of people with hands up, and I know Cindy had put a couple of things in about the assessments that start everything off. Maybe we'll go to Saphira, then Glenda, and then we can maybe talk about assessments, Cindy, and get you to speak a little bit to your questions there. So Saphira, maybe.
Hi, thank you for the great presentation. Yeah, so I'm a graduate student. I'm doing a research project on citizen engagement in home care, and it's a community project in Medicine Hat, Alberta. There we have one local care agency. I also have used self-managed care with my grandma. I'm her caregiver and guardian, which is kind of what inspired me for this project. So there's a couple of things here I'm going to tie together, and then I do have a question for you. Sure. So home care or home and community care, with the new regulations, there's nothing regulating like an advisory council, similar to the way facilities have resident and family advisory councils. So there's nothing stopping that from happening, but in my experience as a home care user, like I don't have a lot of collective opportunities to sort of provide feedback on how service is working for me. So I'm kind of curious, like how we can sort of build in those opportunities, because that's what I hear from the participants in my research project. Self-managed care can be kind of isolating because often you're just hiring, one person, and you're kind of on your own in that experience. And agencies don't necessarily guarantee choice. It really depends on what's being offered in your community. So, there's pros and cons here to all of that. That said, I found in my research that cooperatives, multi-stakeholder cooperatives, offer a really interesting opportunity for more member control in the development of service delivery. It's a novel idea here in Alberta. We don't have any home care cooperatives, but around the world and in Quebec, they've been a leader for this type of service provision. So that's sort of where my project landed, is exploring this idea in Medicine Hat. The community participants have stated that in their view, like they're very interested in a very local neighborhood solution. So like we're talking like block and neighborhood level, where care workers, care receivers, and family and friends are involved in like a relationship, and where they're grouped by like proximity, because as probably a lot of people know, like those care workers are often like jumping around a city, spending a lot of time driving. And that's especially important if the agency who's sort of directing those people are not local to that community. And so just for example, CDHCI, like I said, we have one local agency, but I'm noticing on the Blue Cross website, there's now 18 agencies promoting work in Medicine Hat. None of them are local. The local agency isn't even on there, although they've applied. So I'm kind of curious also, like, what that you're saying the application process is pretty easy, but like, is it possible for, say, a cooperative to operate in this space? And what options might exist to facilitate innovative options like this? Sorry, I know that was a really long-winded. I tried really hard.
No worries. I want to speak to the cooperative. So we do have actually 3 cooperatives in Edmonton. So just throw them out there. We haven't seen it expand anywhere else. And they haven't dove into the CDHCI world at all that I'm aware of. So it would be interesting to see if there's a possibility of something happening there.
Yeah, they might be worker cooperatives. Is that it?
They are
residential, right, Heather? Like they're buildings, right?
They're buildings, yeah.
Oh yeah, this
buildings
is
in
a very
Edmonton.
different thing. Like, I'm not talking about a building. I'm talking about like service provision, a multi-stakeholder.
That's what it is. That's what it is. They've actually they have a contract with a provider to provide service in that building, but it's their and I don't know the ins and outs of the co-op. It's not, I'm not I don't work currently in the Edmonton zone, so I don't know exactly how they function. Just that they do function, and they are separate from regular home care contracting.
I would think that there'd be an opportunity, because within those buildings, they are nonprofit organizations. So, within a neighborhood, if there was a nonprofit organization to then be connecting with Alberta Health Services around that funding, it would seem similar to me. I think it'd be great to explore that. Yeah.
So is it just a simple application with Blue Cross? Like, if a cooperative existed, you're just proving you have insurance, and like it's pretty easy to have that done up? Or
I would suggest they connect with Alberta Blue Cross, because they'll walk them through whatever process that they require. And they can gather that information right on their website. It does have a section that's for clients, for providers, and the providers just go there. They have to be bonded, insured.
Right. Maybe I'll go to Glenda now, and then we'll go to Cindy. I'm just conscious of the time here, which is...
Thanks, Helen. I'll try to be quick. Thank you so much, Heather and Eugene. Such a lot of information to take in today, but great information. So thank you so much. A couple of questions for you. One is, I understand there's an application process to become an authorized provider through the process. Is that something that providers have to, is there an annual audit that providers are continuing to fulfill the requirements to stay on the provider list? Is there something built in as a safeguard for that? And that's my first question. My second question is, as mentioned, the continuing care regulation has recently changed. And within the regulation, there is provision that service providers offer an assessment to family caregivers to ensure that family caregiver health and well-being is maintained, and that they can maintain their caring. So my question around that is, what caregiver assessment criteria tool would be used for that? Have you given thought of how that's going to occur? I'm sure you have. And then what staff training might be in place for provider agencies to require of their staff in order to meet the regulation requirements? Thanks.
Oh, Glenda, you just had to ask that question, didn't you?
Well, I did.
I know.
We just want to make sure that
fantastic.
Service provision is safe.
Absolutely.
And yeah,
absolutely. And what great timing. And literally in 7 minutes, I'm jumping to a meeting, and the first thing on our agenda is the caregiver assessments and having that discussion on what assessment are we going to use as an organization, because it is different in different pockets of AHS right now. So there is one I'm guessing we will likely use that's connected to our new electronic documentation system, but until we have the discussion on which one we feel would be the most appropriate, I'm not sure what that will be, but there will be an assessment. And then the next question that you asked was about the caregiver education. And yes, that's been a stumbling block for us. We did start work on rolling out the education for our AHS staff. It is available for them, our caregiver education. For our, actually, you know, Glenda, I'm not sure, and you probably might even know this more just from other conversations, if we've been able to get that up on the continuing care connection site for our contracted providers.
Right, that is an element that we're working on. We've had preliminary discussions. So caregiver-centered care education is what Heather is speaking of. It is available on My Learning Link and Connect and Click for Covenant Care staff. But yes, for the continuing care sector, we are working on moving it forward and available on their site as well. So it's
Right.
excellent to hear. Thank you so much. And thank
Yeah,
you
and then the other
just for
piece,
the support of utilization of the education that's been developed at the U of A. We are very grateful for partnering with you.
yes, absolutely. The other piece that you'd asked, sorry, it just zipped right out of my head. It was
About annual audits to
annual audits.
continue service provision.
Yeah, so I'll be honest, CDHCI has grown a little bit faster than we had anticipated it growing. We expected a fairly slow rollout, and it literally has blown up tremendously. We have a lot of operators online now. So again, with Alberta Blue Cross, we are working with them to look at how do we do yearly audits, how do we ensure quality. And we also are working on the client handbook that will aid clients in determining and vetting the operators, because of course, because this is self-directed, client-directed program, it is the client's responsibility to vet the vendors and find the vendor that fits their needs and I guess best suits them. So
Great.
work in progress as we move through this new program.
Okay, then I'll get Cindy to jump on here and ask, or maybe it's wanting to share information, because I know you have a lot in that area.
Yes, hi, my name is Cindy Sim, CEO of Team CarePal. We support family caregivers through education, navigation, community, through the use of technology. So I know, just from talking to our family caregivers that, the assessment is a bit of a barrier and a pain point for them in regards to, some of them don't necessarily understand how to answer some of the questions appropriately. And so I'm just curious, and you take culture and language, age, gender, race, all of those things, really affects health outcomes and their access to healthcare services too. So I'm curious, now that you guys are, being faced with recognizing family caregivers, which we're really excited about, will you be integrating them into these assessments further, just with the fluid nature of patients and their loved ones, changing? Sometimes these assessments don't get done until a major event has happened, a hospitalization, and that could be over a year later. Is there a way that, team care or caregivers can be a part of these assessments? Like, I know InterRI has a great checklist for family caregivers so they can monitor their loved ones and, be a part of those, changes. Will you guys be looking at, I don't know, streamlining it, making that assessment maybe a little bit better through education, technology, and integration of caregivers? I guess it's a lot.
Yeah, that is a lot to unpack. We always welcome caregivers to be a part of the assessment.
It is a big area for sure. And I guess one of the things I'm thinking of is that and I don't think this is new news, is that accessibility for caregivers to understand, you know, the RAI is based on being able to pull data and show trends and that kind of thing. So how do we help caregivers have a input into that process that feels really accessible? And some of that is, of course, around having case managers that are able to do that and have the skills in that area with it. But yeah.
Even an education handbook that can be delivered prior to, you know, like a lot of these terms and, you know, whatnot. I mean, caregivers just don't quite understand what they're being asked. And, you know, the assessment is really only done, you know, initially. And then if they don't do it appropriately, you know, a lot of that burden lands on the caregivers to fill in those gaps till the assessment is done again, you know, so they really only have one chance to do it appropriately to get the care that they need. And so I just want to make sure, I'm just curious if, you know, you guys are looking at all in that space to kind of optimize.
Actually, Cindy, you've made a really good point. So we have a client and caregiver handbook that all clients should be receiving upon admission to our program. And we developed it, gosh, I think it's almost coming on 3 years. So it's up for a review. It needs to be reviewed and updated. And I think there's potential there to have a caregiver section that we can highlight and give information to caregivers on how they can connect, because a caregiver can always call in to the case manager at any time and express their concerns, ask questions. It's not just a client that has that ability to connect with AHS. It's, you know, the caregivers as well. So, but I think that's really important, is that we need to maybe add that section in.
Yeah,
I think
and
it's
I would really
No, go ahead,
consider,
Cindy.
you know, using like something like the caregiver checklist again, where they can be educated on looking at those, you know, high level, you know, safety issues, you know, that should be reported, you know, just to give them some guidance, because they're very overwhelmed and they don't know what they should be, you know, focused on.
I think the language is really a key one also, in terms of and I just think of ADL and IADL. We click those off really quickly, and what does that actually mean in a person's life? But yeah, I think language can be really important. So we just landed at 10:30, so lots of great questions and discussions. Thank you, Eugene and Heather, for providing that today. There's still some questions in the chat, and I think Kate's been doing screenshots for us, so we'll try to get some information back as we send out the slides and the link to the recording there. I'm just going to share one quick resource there. There we go. This is an article that, and the link is there, by Cormac Russell and Hoop Hoffman, really around that community-based relational strategy and kind of nurturing community and what's important with that. It's a really nice overall article to read, kind of about the foundations and the level that the different levels that are all involved in that. And then I think we're just at the end there. So again, thank you everybody for joining us today, and take care and have a good rest of your week.